Hello and happy Labor Day to everyone. And I hope you've had a great extended weekend. And thank you for joining us on your Labor Day time off. And I hope you've gotten a lot of rest. We have a very special show for you today. As many of you are aware, a star among us, a now fallen star, Chadwick Boseman, you're recently aware, passed from colon cancer. And even as a cardiologist, I've been getting questions about colon cancer. I'm not even in that specialty. And many doctors, my colleagues, are getting questions from their patients about colon cancer and issues related to screening and risk factors. So we thought it'd be very timely to bring an expert in this area who can educate us all on issues of colorectal cancer, not only the standard treatments and approaches, but what can we do? This approach that we take here on Fresh Natural Live is all about empowering you, the listener, you, the potential patient, empowering you to not only prevent disease, but also maybe reverse illnesses and conditions that you may be faced with. And so our approach is not only to give you the data, which is important, the standard data, but also empower you, give you the tools that would be necessary and beneficial to improve your overall well-being and your chances of surviving cancer if you have that unfortunate diagnosis, but more importantly, to hopefully prevent that diagnosis. Again, someone as young and energetic as Chadwick Boseman can be taken down by this lethal illness. And so it spares no one at virtually any age in the 30s, 40s, and 50s. And so we need to educate ourselves. We need to empower ourselves with knowledge. So without further ado, I'm going to bring on our expert panel. Here with us is Dr. Celeste Palmer. She's a resident pediatrician here in Houston who uses natural approaches to help her patients and family members control their health conditions and improve their overall well-being and reverse illnesses. Our resident nutritionist, Isosa E, aka Raw Girl, counsels patients all over the world with nutritional counseling, behavior modification techniques, and meal planning and the like. She's here to join us with her expertise today. And as I said, we have a special guest today who's going to be educating us on issues of colon cancer. I like to call him a good friend. I met him for the first time in person earlier this year, Dr. Ed McDonald. Dr. McDonald is a board-certified gastroenterologist. In other words, he specializes in the GI tract. He's going to discuss the underlying cause of colon cancer with us today. He's board-certified and dedicated to improving the health of individuals and communities through nutrition and education. He obtained his undergraduate education at the University of Michigan and his medical education at Northwestern University Feinberg School of Medicine. During medical school, he developed an interest in community health education and subsequently developed a program focusing on training local hip hop and spoken word artists as health educators with funding support from the Albert Schweitzer Fellowship. After medical school, he completed an internship and residency in internal medicine at Northwestern. As a resident, Dr. McDonald often shared recipes with his clinic patients at the Jesse Brown VA Medical Center. Witnessing the effects of simple lifestyle interventions in health of his patients prompted him to seek further training in nutrition. He then completed a fellowship in clinical nutrition at the University of Chicago and culinary training at the prestigious Kendall College School of Culinary Arts. He subsequently completed a fellowship in gastroenterology at Rush University Medical Center. Dr. McDonald currently is an assistant professor of gastroenterology at the University of Chicago. He is also associate director of the adult nutrition at the university and instructor in culinary medicine. Dr. McDonald has conducted basic science research in gastroenterology with funding through the National Institute of Diabetes and Digestive and Kidney Diseases. He has presented research at national meetings, including Digestive Disease Week. His current research interests include small intestinal disorders, obesity, nutrition, education, health disparities, and colon cancer prevention. His articles have been featured in scientific journals, including the New England Journal of Medicine. So without further ado, welcome to the stage, Dr. McDonald. I'm out of breath from reading that long, prestigious background, but I wanted to get that in. I know it's long, and I know you like to keep it simple, but there's some critical aspects of your background that I really wanted our audience to hear about and learn about. And the fact that you've integrated the culinary arts with your professional career in gastroenterology. I mean, we do culinary things in my practice in cardiology. I think it's more poignant that you do it in yours, GI tract. I mean, I think it should be a requirement that every gastroenterologist be trained in culinary arts. What do you think?
I mean, I would agree with you. And, I would say cooking is fundamental regardless of what field of medicine you're practicing. I think, to me, controlling your food is one of the best ways to control your health overall. So if we as physicians are trying to help people become healthier, we have to be equipped to have that conversation about how food plays a role in your overall health.
Yeah, and I agree with you. It starts and ends at the dinner table, and we eat ourselves in this chronic illness, and it's a problem. But again, the nation is somewhat heartbroken on the recent tragedy of Chadwick Boseman, and as we talked behind stage, you getting a lot of calls and questions about colorectal cancer and the like. Why don't we start from the beginning? Colorectal cancer, what is it? What are the fundamentals? What is it? What are the risk factors? How do you get it? Start us off with a kind of an overview so we can put some context behind this.
Yeah. So, first and foremost, I'm glad that we're having this conversation because I don't like diagnosing people with cancer. I mean, that's probably one of the least enjoyable aspects of my job, especially oftentimes when people come in for colonoscopies. These are strangers. These aren't necessarily people that I've seen in clinic and developed a relationship with. Sometimes there are people who are solely here just for the procedure. And my first time meeting them is right before the procedure. And essentially telling a stranger that, giving them the diagnosis that it may be cancer, that's tough. And I take no joy in doing it. But most of my job is not diagnosing cancer. Most of my job is preventing cancer. So let's talk about what cancer is. Let's start there. And I think it's a reasonable place to start, primarily because years ago when I was a medical student, I was volunteering at this clinic called Project Brotherhood. Okay, so I'm in Chicago. And Project Brotherhood was a clinic for Black men on the south side of Chicago. And we had a grant through the American Cancer Society. And the grant basically was training local barbers as health educators. So we actually decided to focus on colon cancer. And I was one of the medical students who was leading the educational activities for the barbers. And I was also doing some of the focus groups for the patients. So with our focus groups, we just took brothers from the community, brothers from the south side of Chicago, specifically in the Woodlawn neighborhood. And we just asked them a series of questions. And one was, what is cancer? And the responses I got when I asked that question to some of the brothers in the neighborhood, it was shocking. But it also showed that a lot of people don't have a basic understanding of what cancer is. Okay. So some of the responses that some of the men gave me were things like cancer is a fungus that grows on you. Okay. Another response was cancer is something that when the doctors don't know what's going on, they just say you have cancer. Another response was, when the doctors really just want to take all your money, they just tell you that you have cancer and it's all just about getting money. So all those answers are 100% false. Cancer is basically uncontrolled cell growth, okay? So you have cells that are growing and multiplying in the body. And normally under certain normal circumstances, they grow in a controlled fashion. And if there's any errors in the cell, specifically in the DNA, which is the part of the cell that tells the cell kind of what to do and how to behave, if there's errors, the cell has a mechanism in which the cell just commits suicide. It can just kind of die off. And we call that apoptosis. That's the technical term. So all the damaged cells should not really have the opportunity to kind of proliferate and multiply because under normal circumstances, the body's going to put those damaged cells in check. But in the setting of cancer, our ability to check those cells is abnormal. It's damaged. It's not functional. And as a result, those cells can then multiply to the point where they can grow to form a cancer. And cancer is basically when those cells are really just starting to invade areas where they should not belong. And then when we talk about a cancer metastasizing or spreading, that's where a cancer is basically invading to other parts of the body or other organs. And one way cancer can do that is by those cancer cells can actually get into our bloodstream and travel along the bloodstream and actually land on other different organs and other different parts of the body. And essentially that's one form. And then cancer can also travel through our lymphatic system. So we have a lot of other vessels in our body. We're just not made of blood vessels. We also have lymphatic vessels. And the cancers can travel through those vessels and invade other parts of the body.
So let me ask, I'm sorry, you mentioned a very important point here, and I want to make sure our audience is on top of that. So first of all, you said cancer is uncontrolled cell death, and then you mentioned apoptosis, which is programmed cell death for damaged cells.
Yeah.
And so in this case of cancer cells, this normal way of programming cell death for a damaged cell or a sick cell is somehow impaired. Is that correct?
Yes.
So apoptosis and again, programmed cell death, and I'm going to speak from our audience standpoint, our cells are programmed to kill itself, commit suicide if it's damaged and not doing good or potentially doing harm to the body. But that ability to kill itself is impaired in the setting of cancer.
Yeah.
That's kind of unique to cancer. Yeah.
Right. So some of the
mutations. Make sure our audience understood. You're hitting some hot points there. And I just want to make sure people get it. I'm making notes here too, but sorry about the interruption. Go ahead.
No problem. So colon cancer is basically cancer that originates in the colon, also known as the large intestine. We also call it colorectal cancer because the rectum is also part of the colon also, but it's just a specific part of the colon, which we call the rectum. Other parts of the colon, you have your ascending colon, your transverse colon, your descending colon, and your sigmoid colon. So colon cancer can arise in any of those areas, basically. So right now, colon cancer is pretty much the second leading cause of cancer-related death. So it happens. I mean, colon cancer is out there. One of the reasons I became a gastroenterologist. I'm from the South Side of Chicago. I remember going to church and I would hear people being sick and shut in with this thing called colon cancer. As a youth, I didn't really know what it was, but it's something that came up over and over and over again, along with diabetes, along with heart disease, along with strokes. And as I got more interested in medicine, colon cancer is one of those things that I eventually looked up. And eventually my father, when he had his colonoscopy, I had the opportunity to talk to the gastroenterologist about colon cancer, what the gastroenterologist does. So, so on and so forth. The rest is history. I became a gastroenterologist. But colon cancer, one of the reasons why I saw a lot of colon cancer growing up on the South Side of Chicago is because South Side is predominantly African-American Black population. And unfortunately, colon cancer has higher rates in the Black community. So people of African descent in America are 40% more likely to die from colon cancer than compared to white people, and also 20% more likely to get diagnosed with colon cancer. Now, the reasons for these disparities is complicated. So there's a lot of different factors that go into that. I mean, racism is definitely a contributing factor in all the things associated with racism. Diet can play a role. Lack of access to healthcare, not getting screening, not being offered healthcare, even for people who do have access. So there's sometimes when people have access, their primary care doctors aren't even bringing up the fact that you should get screened for colon cancer, which that, in some ways can also be linked to racism. Physical activity, there's a lot of different things that can put people at risk for developing colon cancer. As far as symptoms, majority of these cancers are completely asymptomatic. So, and I really want to stress that point, because a lot of times when I go out in communities and I talk to people about why you should get colon cancer screening, majority of people who don't necessarily want to have a colonoscopy or any screening, they say things like, "Oh, I feel fine. I don't have any issues. I don't need to have this." Or, to a lot of folks in my plant-based community, a lot of people feel like if they're vegetarian or vegan, they don't necessarily need a colonoscopy because they're eating a healthy diet. I would disagree with that. Although the diet in of itself can offer a lot of protection in terms of decreasing the risk of developing colon cancer, hands down, a plant-based diet has a significant amount of power in terms of decreasing that risk. But there is nothing out there that's 100% protective. And then also a lot of people weren't not necessarily vegan their entire lives. So, just because you became a vegan, last year doesn't necessarily mean that the past 30 years or 40, 50, 60 years of eating meat every day is not necessarily going to catch up to you.
Yeah, I'm glad you pointed that out because, we all, I think in all of our practice, we see patients who are very aggressive with the diet and eat a plant-based diet, and they eat the so-called vegan diet, which number one, they may not be eating the healthiest of vegan diets. So just like you said, they cut out animal protein 5 years ago. Doesn't mean that something that started 10, 20 years ago is not still lurking and progressing. And so that's one. Two, there are other environmental factors, our water and other things that we're taking in to our system that can predispose to these things to some extent, even though food might have a bigger part, but there are other factors. And so I'm glad you mentioned that because many people in our vegan community don't want to get screening of any type when in fact, they could have colon cancer, heart disease, and all of those things that we need to be more aggressive with their vegan diet. But anyway, I'm glad you pointed that out because we hear that a lot.
Yeah. So, I mean, for the vegan community, look, I tell everybody a whole food plant-based diet is definitely one of the most effective tools that we could use to decrease our risk of developing a lot of conditions, not just colon cancer, but a lot of chronic disease in general and other cancers, including colon cancer. But, again, if you want to play it as safe as possible, if you have access to screening tests that can really help you define what your risk truly is, take advantage of those risks, those tests, because you just don't know. And I feel like more information is always better than less information.
So basically, we got risk factors and the like. You've started going into the whole aspect of prevention. Briefly, give us the formal information on the screening, and then get us into other. Most people think screening is a form of prevention, or early colonoscopy is a form of prevention. In some ways, it can be if you catch something early, but there's some other natural prevention ways I want to talk about. But help us on the screening. What are the ages? Who should get colonoscopy? Also, you have this new test, ColaGuard, WIAC test. Where do these things all fit in the scope of what we need to do in terms of screening for colon cancer?
Yeah, so those are all good questions. So colonoscopy is probably the screening test of choice for most people, primarily because it's the test that can actually help prevent colon cancer as opposed to just diagnosing something. So with colonoscopy, we can prevent colon cancer in a couple of different ways by identifying these growths called polyps. So polyps are precancerous growths that aren't cancer, but they have the potential to turn into cancer. And, in general, it probably takes a polyp anywhere between 3 and 10 years to actually turn into a cancer. So these cancers don't develop overnight. These are things that kind of brew for some years. But with our colonoscopies, we can identify the polyps and basically remove them so they won't ever have the opportunity to become cancer. So we tell people, based upon our guidelines, African Americans should start getting colonoscopies or colon cancer screening starting at age 45. And these are African Americans with no family history of colon cancer. Now, there's a recent switch where the American Cancer Society has recommended that all Americans starting at age 45, regardless of race, creed, or color, get their colonoscopy at age 45. But they're the only society who's made that recommendation. Other societies recommend that everybody else who's not African American start their colonoscopies at age 50. And then when you have your repeat colonoscopy, that all depends on your family history and what they find in your first colonoscopy. Now, for the folks who are, 60, 70 years old, who've never had a colonoscopy, I don't want you to feel like it's too late because you're not 50. You can still go ahead and get your colonoscopies. You just started a little bit later. I would say, doing it later is definitely better than getting diagnosed with a cancer that could have been prevented. Now, we do say people over the age of between 75 and 85, colonoscopy is optional in that age group. And a lot of it depends on how healthy people are. So if you're, healthy, if you've had your previous colonoscopy, you've been on a good plant-based diet, 75 and 85, you may not really need a colonoscopy. Or if you're super sick and you really can't tolerate being sedated for a colonoscopy, in that age group, you may not need a colonoscopy because it's probably too dangerous. 75 and 85, I mean, if you're healthy and you really want to undergo further colonoscopy, I feel like that's a conversation you should have with your physician to decide the risk and benefits of doing colonoscopy within that specific age group. But everybody age 50 and up should be having some form of colon cancer screening. Now,
I'm sorry, those older ages, like you mentioned, 75, 80, 85 and older, this test ColaGuard. I mean, I've had some patients in those age groups and we kind of, waving up the colonoscopy. Does that add is that any beneficial? I know it's not the same. You can't take the polyp out, but does that help in any way?
So it does. ColaGuard is a DNA-based test. So if there's cancer cells, these cells have DNA abnormalities from these mutations that we just discussed. And the ColaGuard can pick up a lot of those mutations and a lot of those DNA abnormalities. So it's a stool test. It costs about $600 if it's not covered by insurance. So if you're trying to pay for it out of pocket, it's probably going to be around $500 to $600. Oftentimes insurance will cover it, but that may vary. Medicare and Medicaid, Medicaid does not cover it. Medicare, it may depend on what type of plan you have to see whether or not it's covered. But nonetheless, it's just a stool test. And in terms of its ability to pick up cancer, it's pretty good. So it has a specificity for cancer about like 92%. So it picks up a significant amount of cancer. It's not the greatest for picking up polyps. So you can have a whole bunch of polyps and have a negative ColaGuard test.
Gotcha.
Now, there's another stool test that's pretty good. It's called the FIT test. So it's a little bit more complicated than Guaiac test, but it still detects blood in your stool.
How do you spell that? The FIT?
Yeah, so FIT.
Okay.
Yeah.
Is that an acronym for something or?
Yeah, fecal immunochemical testing.
Okay.
So it basically can pick up 74% of cancers, colon cancers. And it also isn't really good at picking up polyps. So for people who are really trying to be focused on prevention, I would say the test that is probably the most effective at preventing colon cancer is going to be the colonoscopy. Everything else is really focusing on early detection. And as far as prevention, I mean, outside of me doing a colonoscopy, your diet, your physical activity, looking at environmental exposures, all that is 100% important. And also being aware of your family history. So family history is going to dictate when people get their colonoscopy also. And this is one of the reasons why we really need to have conversations with our brothers, our sisters, our parents, and all our first degree family members about, whether or not they've had colonoscopy, and if so, did they have any issues? Did they have any large polyps, or did they actually have cancer? So I know sometimes we want to keep our health information secret from family members, but in this setting, that is probably the worst thing you can do. So people who have a first degree relative who've had colon cancer, especially someone diagnosed under the age of 60, you got to get colonoscopy sooner. So if you have a family member with colon cancer that was diagnosed under the age of 60, you should get your first colonoscopy at age 40, or you should get it 10 years before your family member was diagnosed with cancer or a large polyp. So if a family member, so case in point, Chadwick Boseman, he was diagnosed, I believe, at age 39. So his children or his brothers and sisters, they should get their colonoscopy starting at age 29, as opposed to waiting to age 45.
Wow. Now, the data on this. So, and there's a question from an audience I'm going to throw in here on colonoscopy in just a minute. But so the 10-year preceding. So basically, if you have a family member with colon cancer, you should get the colonoscopy 10 years prior to their diagnosis or at the age of 40, whichever comes first. Is that correct?
Whichever comes first.
So then if you have a family member diagnosed with colon cancer at 39, then you should get it at 29. What is the data? Give us a little bit of the information on the data that supports this. Do they find a higher percentage of polyps 10 years prior using that parameter?
Yeah, I mean, a lot of it is really just for the sake of colon cancer prevention. So we know that the first degree family members tend to have a higher likelihood of having advanced polyps or cancer. So instead of giving people the opportunity to actually develop cancer, you want to catch those people before they actually develop cancer. And that's the purpose of doing a colonoscopy, because we can not only identify if there's polyps, which have the potential to turn into cancer, we could remove those polyps and, essentially minimize that potential, or, pretty much almost take it down to zero.
So if you do a scope and you see 10 polyps and they're just those 10 polyps, you take them all out, there's nothing else that's likely to be there to cause a problem. Is that correct?
Well, no. So no one's 100% perfect. So, I mean, people can easily miss polyps.
Okay.
And polyps can also return. So that's one of the reasons why, if you have polyps, you're going to have to come back for what's known as surveillance colonoscopy. And the interval in which you get our surveillance colonoscopy depends on how many polyps you've had, and also the size of polyps that you've had. So if you just had one small little polyp, you can come back in 5 to 10 years. If you had greater than 10 polyps, you need to come back in a year. If you've had, a polyp that was a centimeter or greater, you should come back in 3 to 5 years. If you've had 2 polyps that were smaller than a centimeter, you should come back basically 5 to 7 years.
So 2 polyps, 5 to 7 years. What was your one, 3 to 5 years? A 3-centimeter polyp?
A polyp that's a centimeter or above. Or if you had 3 polyps that were less than a centimeter, you should come back 3 to 5 years.
Gotcha. Wow. Now, let me go to a question from Catherine S.
Oh, can I jump in and say one more thing?
Please.
So, I will say there's a lot of shady gastroenterologists out there that are making people come back every year.
Yeah.
If you don't have Lynch syndrome, or, if you don't have like a history of cancer and stuff like that, like, you should not be coming back every single year for colonoscopies. And I see people do this, but that's not in our guidelines.
Well, I want you to touch on Lynch syndrome in a minute. There was a question before we came on about Lynch syndrome. I want you to help us with that. But listen, Catherine S., again, she wants you to clarify some on the colonoscopy in older patients. Did you say colonoscopy in older patients, 70, 75 plus, could be dangerous? In what way? Please speak on this. I didn't get that from you. Can you speak to the colonoscopy in older patients?
Yeah, so specifically our guidelines say that colonoscopy between the ages of 75 and 85 is optional. And we really shouldn't be doing screening colonoscopy in people over the age of 85. And screening colonoscopy is different than if there's something wrong. So if somebody's coming in and there's a whole bunch of blood in their stool and we have to do a colonoscopy to actually stop the bleeding, and you're like 85 years old, by all means, it's reasonable to get that done. But between 75 and 85, sometimes people can pick up other conditions that can make doing any procedure, not just a colonoscopy, but anything that involves sedation, a little bit less safe than people who don't have those conditions. So when people are sedated, not only for our colonoscopies, but for surgeries and stuff, we have to take in consideration their baseline health status to determine the safety of anything that we do. And we always have to have a conversation, do the risk outweigh the benefits? So, case in point, if someone is 75 years old and they're on the heart transplant list and they have an LVAD, and, I don't know if that's the best person that we should just be doing colonoscopies on. Now, sometimes people need to have a colonoscopy in order to get on the transplant list, and that's a different conversation. Yeah. But that may not be the best person to say, well, let's just do this colonoscopy, because now you have to deal with the risk of sedation. You have to deal with other risks. And it's really the risk of the sedation, not necessarily the risk of the colonoscopy itself, because the colonoscopy is really not, really a painful process. But with sedation, to get sedated for a colonoscopy, the medications that we use to put people asleep can also make the blood pressure go low. And in people who have, heart disease, having a lower blood pressure may not necessarily be the best situation you want to be in. And that's really a case-by-case conversation. So that's why 75 to 85 is optional and really requires a conversation with your physician.
And I want to just, I mean, I'm glad you pointed that out. Again, just for our audience to understand, it's really a risk-benefit ratio. And the part that's optional is just an asymptomatic screening colonoscopy, optional from 75 to 85, and asymptomatic screening colonoscopy, not recommended greater than 85. But if they have a problem that needs to be addressed, then they have to get a colonoscopy based on that problem. In that situation, it's a case-by-case basis, and you determine whether that individual can tolerate the procedure or not. And so I just want to, Catherine S. asked a great question. So yes, 75 plus can get it. It's optional after 75. But and I don't like to use the word dangerous. There's always a risk-benefit ratio. If a simple, toenail clipping can be a high risk if there's no benefit to it. So I mean, so it all depends on what you're doing, what you're getting out of it. And so again, screening colonoscopies on the older ages, over 85, you don't do it. Optional 75 to 85. So I want to make sure Catherine S. got that. We got another question on Lynch syndrome. So you got into that a little bit, where some gastroenterologists doing annual colonoscopies is not a standard except for Lynch syndromes and other conditions. So what are those conditions where you're doing these annual colonoscopies? And then, of course, help us out with Lynch syndrome.
Yeah, so the colon cancers that we typically see, and everyone's going in for their screening colonoscopies, we're trying to prevent and identify sporadic colon cancer. Okay, so these are colon cancers that just come spontaneously from being exposed to different environmental toxins, the food that we eat in the standard American diet, et cetera, and maybe a slightly genetic component. But there's other colon cancers out there that are hereditary. I mean, 100% hereditary. Like if you carry the certain genetic abnormalities, your chances of getting colon cancer are, almost like 90%. So Lynch syndrome is one of those syndromes. And the people who have Lynch syndrome, they carry a mutation in what's known as DNA mismatch repair. So whenever our DNA replicates itself, all the nucleic acids and the bases, they got to line up appropriately. And sometimes when the DNA is replicating itself, there's a mismatch. Now, normally, our DNA has the ability to actually identify these mismatches and fix the DNA so everything lines up appropriately. But in a setting of Lynch syndrome, that ability is impacted by mutation. So all these errors can eventually, over time, accumulate to the point where people are going to develop a lot of polyps, not just a couple of polyps, I mean hundreds of polyps, and then eventually cancer. So, and not just colon cancer, there are people with Lynch syndrome who can develop other cancers. So colon cancer, intestinal cancer, breast cancer, endometrial cancer, kidney cancer, bladder cancer. So there's a lot of different cancers that are a part of this whole Lynch syndrome, so to speak. So people who are at risk for Lynch syndrome, if you have multiple first-degree family members who developed any of these cancers, where these are the folks like, oh yeah, cancer runs in my family. My grandmother had bladder cancer in her 40s. My mother had breast cancer. My brother had colon cancer. That's the scenario in which you should probably get tested for Lynch syndrome. And people who do have Lynch syndrome, they're going to be followed. They're going to start colonoscopy a lot earlier. So we recommend that people get their colonoscopies at age 20 to 25, where you're starting your first colonoscopy. And then you may be doing colonoscopies every year or so.
Quick question, Ed. When you have that family history, does the insurance acknowledge that and cover that for those patients?
Yeah, I mean, if you have that specific family history, your insurance will definitely cover it. Okay. And sometimes getting diagnosed can be a little bit complicated because insurance companies, they get a little bit funny when it comes to paying for some of the genetic testing. But once the diagnosis is made, As long as your gastroenterologist is doing the colonoscopies within the specific specified guidelines, there shouldn't be any issues with getting coverage.
Wow. That's fascinating stuff. Do people who are younger, do they typically have, in other words, if you were to get 100 people, not that it's easy to get 100 people, but let's say you get 100 patients, ranging age from 35 to 45 with colon cancer, compared them to 100 patients age 65 to 75 with colon cancer, would you see a greater propensity of these genetic predispositions in that younger group compared to the older group?
I mean, most of the hereditary cancers, they start at an earlier age. So in the older population, you're pretty much just dealing with sporadic colon cancer. That's not, I mean, there may be a genetic component, but that component is not as strong when it comes to these hereditary cancers. With these hereditary cancers, I mean, the genetic abnormality is so strong that oftentimes people in their 20s, because they've seen their parents, their brothers and cousins and everybody get cancer, a lot of times people just say, you know what, just take my colon out. Like, I don't even want to deal with all this stuff. Let's just take the colon out to decrease the risk. And,
yeah. Wow. So,
but for the most part, these are rare forms of cancer. Okay, so most people, most of the audience out there listening, we're really just focusing on sporadic colon cancer without getting too in detail with all the different hereditary syndromes, because there's a bunch of them. Lynch syndrome is just one of them, but you have FAP, you have Cowden syndrome. I mean, there's so many of them, and most of these actually require a geneticist to actually help get the diagnosis.
Wow. Fascinating stuff. I'm going to go back to, they ask a lot of practical questions. I just want to make sure that from a practical standpoint, people are getting some insight. Patrice Moshe asks, should everyone be drinking the same amount of pre-colonoscopy drink? I guess that's the bowel prep. For example, would a person following a plant-based diet need as much cleaning out as a person who eats meat and carbs? So what is your answer to that?
Yeah, I mean, so the diet really doesn't impact cleaning out, and it's complicated. So I know a lot of people have seen images of like someone's colon and it looks like it's caked and covered with a whole bunch of stuff, and a lot of people say, well, this is because of they're on a animal-based diet. The issue with colonoscopy and a vegetarian diet is really fiber. So fiber in general is 100% great for you. And if you want to decrease your risk of colon cancer, you really have to eat a diet rich in fiber. And there's a lot of studies that have clearly demonstrated that. But the problem with fiber and colonoscopies, the fiber, we don't digest it well. So the fiber can end up in our colon where it can actually interfere with my ability to visualize the tissue of the colon. So in preparation for a colonoscopy, we tell people to do what's known as a low residue diet, just for a couple of days. And then the day before the procedure, you're going to do a clear liquid diet. So you're just drinking liquids all day. So it's almost like if you want to use the word detox, you can use the word detox. But it's really just, liquids, and it's really putting your body in the best position to eliminate all the stool that you have inside of you. Because if there's a whole bunch of stool in there, the test is not going to be adequate. So you're just going to see stool. You may miss polyps because there's stool overlying some of those polyps. So in terms of the bowel preparation, there's a lot of different bowel preparations out there. And I feel like this is probably a good opportunity for the listeners to know that there are other options. So the standard bowel preparation that most people give, because it's covered by insurance, is Go Lightly. So Go Lightly is a gallon jug. I mean, it's a lot. It is, and it doesn't really taste good. I would say the toughest part about the procedure is actually drinking the bowel preparation to clean yourself out. But there are so many other options besides Go Lightly. So you have bowel preparations that are about half as much, that are a little bit tastier. I mean, none of this stuff tastes good. So I would not go into it thinking that, this is going to be a tasty experience. It's basically you're drinking a whole bunch of liquid that's going to give you diarrhea and clean you out. But it serves a purpose. And the purpose is, if you're going to have someone actually look inside of you, you really want to have them, have a good look, as opposed to having to come back multiple times in order to get that good look. So I tell people to really just talk to their gastroenterologist who's doing their procedure and make sure you really follow the diet to a T, as opposed to what I've seen people say, well, I'm a vegetarian, I'm a vegan, I should be clean, so I don't have to do all that. Like, that's not true. I've seen people make that mistake, and I see them before the procedure. I'm like, yeah, did you drink all that stuff? Oh man, I'm vegetarian, I drink all that. And
yeah,
it's like, you do.
we go back through it again. We got some excellent questions, but I want to get you. I brought some images to share with the audience, and I think this will be better. Picture tells 1,000 words. So I'm going to go through these and let you describe them to us in the order you recommended. The first image here, I'll share with the audience. What are we looking at here?
Yeah, so that is someone holding up our camera. So that's the colonoscopy. So the camera is thin. It's probably about as wide as your pinky finger or ring finger or so, depending on the size of your fingers. It's not a wide camera. And for most people, especially men who've had a digital rectal exam for prostate cancer, I would say that digital rectal exam is probably more uncomfortable than us inserting a camera, because the camera is smaller, thinner, and it's flexible.
Okay. So this next image here.
So that's what a polyp looks like. So the arrow's pointing to the polyp. So notice how it kind of stands out compared to the rest of the lining of the colon. So the polyp, again, what we're looking at is abnormal cell growth. So those are mutations in the cells that are lining the colon that have allowed these cells to grow and replicate to the point where they're forming a polyp. Now, it's not cancer because those cells don't have the ability to actually invade and spread. And once those cells gain that ability to invade and spread throughout the body, that's when we start calling it cancer.
Wow. And this next image here is doing some of your handiwork.
Yeah, so this is a good example of one way that we can remove polyps. So the doctor in that picture, they're using what's known as a snare. It's almost like a metal lasso. So you can lasso the polyp, and we can, some of the snares are real sharp, so you just cut through it. And some of the cells, the snares, you can run cautery and electricity, and you can kind of use electricity to kind of burn the polyp, and it'll cut off.
Now with a polyp, if you snare it, if that little tip here falls off, I guess it travels through the colon and passes with the bowel. Is that right? Or do you pull it out with your snare?
Yeah, so we take it out.
Okay.
So we take it out, so we take it out and we send it to pathology so we can determine what type of polyp it is and make sure that there's no cancer on the inside. But just looking at these don't look cancerous.
Gotcha. And here's one. This looks uglier here.
Yeah, so this is cancer. And one way you can tell it's cancer, you see how it's almost ulcerated and it's almost sucked in. And so that part where it's sucked in and ulcerated, that's where the cancer is actually invading into the deeper layers of the colon.
Wow. So this doesn't look good. So this is where you do the colonoscopy, you do the scope on someone you don't know, and you have to come and give them some bad news.
Yeah. So, I mean, I never tell anybody they have cancer until I get results of biopsies. But I don't sugarcoat things. So in this situation, I would take a lot of biopsies, and after the procedure, we'd sit down and have a conversation in terms of what the possibilities could be. And the possibilities, just looking at this, cancer would be one of the possibilities. In certain situations, ischemic colitis could look like this. And I've seen some ischemic colitis where it looks like a cancer, but it's really just ischemia, which is basically low blood flow. And oftentimes people who have ischemia also have coexisting heart disease. So the blood vessels are so clogged with plaque and cholesterol and everything. Not only are they at risk for having heart attacks, you can also get decreased blood flow to the colon and get these ulcers or this inflamed appearance.
Wow. And this is one we talked about not seeing, but it kind of shows that spectrum, the little polyp and the snare, and then you got something that looks ulcerative, that looks like cancer, to give everybody a summary look at that.
Well, at the bottom, it's not cancer. That's actually a larger polyp. So some of those polyps can get pretty big, yeah.
See, I'm not a gastroenterologist. I'm glad you're here. That's important. That's amazing. That's impressive. we had some excellent questions here that I want to get through. Someone, now this is one that you're going to get in an audience like this. There was actually a question about environmental toxins, or someone mentioned environmental toxins. We talked about the food. Are there other environmental what about water? You know, you hear places like Flint, Michigan having terrible water. And, you know, I had my water tested here in Houston. I had got a whole house water filter. We have radiation on water. We got all sorts of other toxins on water, and I'm showering in it and, you know, bathing and brushing your teeth in it. How much do we know about water or other environmental toxins in our environment that could be contributing to colon cancer?
Yeah, so that's a good question. And in general, we need to do more research about the role of environmental toxins and cancer in general, because right now we are exposing ourselves to, you know, thousands of chemicals that haven't really been tested every single day. So even the skincare products that we put in our skin, a lot of the stuff, when you read the back of these labels, these are chemical ingredients that most people can't even pronounce. And most of the stuff that we're being exposed to, I mean, it sounds like something straight out of a chemistry set. So, you know, with water, depending on where you're at, there may be a lot of different pollutants in the water, including pesticides, including, you know, definitely chemicals that are carcinogens, unfortunately. And, you know, with the Trump administration, they've actually rolled back some of the protections that were put in place, I believe, under Richard Nixon to keep the water clean. Yeah.
Yeah. Now,
so, with toxins in general, I mean, hands down, the majority of the toxins are really coming from the foods that we eat. Okay. So not only the foods that we eat, but also the way that we prepare the foods. Okay. So if you think about toxins, your processed red meats are definitely a source of toxins that can increase the risk of cancer. As a matter of fact, the WHO listed like hot dogs and some of these processed red meats as one of the most common carcinogens that people are exposed to. So your bacon, your sausages, your deli meat, all these foods have a lot of nitrite. And the nitrites in of itself are carcinogens. So this is stuff that's toxic to the cells that line our colon and definitely can increase the risk of cancer. With red meat in of itself, the heme, the pigment that gives red meat its red color, is also toxic to the lining of the colon. And that is something that can increase the risk of developing cancer. So for your listeners, red meat not only includes beef, but it also includes pork, lamb, and then even duck breast is considered a red meat because the duck breast is actually red and it has some heme in it.
Wow.
Another toxin, when we start cooking these animal products, if you cook them with high heat techniques, such as barbecuing, grilling, roasting in the oven, and also deep frying. So those high temperatures can actually create carcinogens within the meat itself, specifically in areas where there's char marks. So those grill marks and those burn marks that a lot of people love, there's actually carcinogens, cancer-causing agents within those marks. So those marks are rich with heterocyclic and also polyaromatic hydrocarbons. So these are all toxins that are technically environmental toxins that can increase the risk of cancer.
That's amazing. It's you know, you mentioned the data that came out from World Health Organization, and it was pretty clear. It was a class 1 carcinogen in the meats that you mentioned, but our government did not respond to remove these things from the market. I mean, you'd think you would. I mean, I don't know what is your take on that? I don't want to get too much into politics, but
yeah, I mean, my take on it is money, and it comes down that there's too many people making money off a lot of these products, and where there's money, there's also power and influence. So you know, big food and big agriculture, like this is a huge industry with a lot of influence when it comes to our political system. So these corporations have a lot of lobbying power, and right now with the Trump administration, a lot of people in charge of, you know, regulating some of these foods. A lot of these people were actually running the companies not too long ago. So it's really a scary time because the people who are supposed to be protecting us are also the people who are related to folks who are selling stuff that's causing harm in the first place.
Yeah, Colin Campbell talks about this in his years of experience in dealing with these industries where you have like, as you just pointed out, the people who are supposed to be protecting us have a special interest in the people who are promoting these toxic foods. I mean, it's I don't know. It's horrible. Hopefully shows like this will help educate the community. Kelvin Douglas asked, interesting, what is the relationship between reversing certain cancerous diseases with a holistic diet and hereditary family cancer? So I guess, can a holistic diet help out in people with these hereditary diseases?
Yeah. So, I mean, that is an area that's understudied. And in general, we need to do more studies really looking at the impact and power of food. So there have been plenty of studies known as in vitro studies where you take cancer cells and you expose them to nutrients from food. So specifically nutrients like antioxidants and some of the pigments in a lot of plant-based foods. And a lot of the foods in these in vitro studies have anti-cancer properties where the cancer cells actually die when you expose them to either nutrients from the food itself, or they've done studies where, you know, they'll take someone who's vegetarian or vegan and they have a high amount of antioxidants within their bloodstream, and they'll take the bloodstream from someone who's been eating a plant-based diet or a diet rich in some of these antioxidants, and they expose the blood to the cancer cells, and the cancer cells will also die off in that setting. Now, what does that mean in the actual human body? So we have to do more studies to translate the results of those in vitro studies to actually, you know, not just one person, but large numbers of people. So we can start to really, you know, say like, this is what the impact of the diet is in this setting. So in hereditary cancer, I mean, there's not a whole lot of studies that I know of that I can quote to say, you know, the impact of a plant-based diet in someone who already has cancer, specifically hereditary cancer, is going to be X. I don't know. I think in general, primarily based upon a lot of those in vitro studies, if you are trying to prevent cancer, I feel like getting on a whole food plant-based diet is definitely one of the tools that you can use to decrease your risk of preventing cancer. And that's even with the hereditary cancers. It may not necessarily be the only tool I would rely on, but it's definitely a tool in the toolbox. If you have cancer and you have this diagnosis and now you're trying to figure out, okay, well, you know, how do I get rid of the cancer? How do I survive the cancer? Diet plays a huge role when it comes to managing cancer. So that same diet that's rich in antioxidants and foods with anti-cancer properties is definitely the diet I would be on if I was diagnosed with cancer, as much as I could tolerate. Now, does that mean that the diet takes the place of chemotherapy, takes the place of surgery, takes the place of some of these other interventions? You know, that's an area that requires further study. And more than likely, I mean, I recommend that people have a combination approach. But, you know, those questions really depends on, you know, the stage in which you're diagnosed, and, you know, your overall health and also your philosophy in terms of how aggressive do you want to be in terms of your actual treatment. You know, there's some folks you get, you know, diagnosed with stage 4 cancer, you may not want to have any of this stuff because even when you look at some of the chemotherapy literature, depending on the stages, some of the medications aren't super effective, but they can also have a whole bunch of side effects. So there's some folks who are like, you know what, I may not even want to have some of this stuff because I'm really concerned about the side effects. And if the cancer is already spread, I mean, that is a reasonable conversation to have. And in that setting, I've seen people are like, well, let's see what this plant-based diet, or let's try some of these alternative treatments, because even the traditional stuff, you know, is not necessarily 100% effective in terms of curing. Folks are trying to think about their options.
What we do, I'm not going to present myself as an expert in this, but I think it's relevant to the conversation. We've been providing a lot of nutritional support with people with advanced cancers. Yeah. And one thing I'm seeing, and again, our numbers are very small, so, you know, don't take this as scientific studies or evidence, just anecdote. But we're seeing patients with advanced cancers. Now, this is colon cancer, renal cancer, other cancers. When we do aggressive nutritional intervention, plant-based diet plus intravenous super nutrients, vitamin C, and the like, and they're getting chemotherapy, what we're seeing is that the patients tolerate the chemotherapy better. Their anemia corrects, they do better overall physiologically, and it looks as though the nutritional support is helping protect the normal cells from the ill effects of the chemotherapy. We're seeing less liver failure. I have one person, this is not colon cancer, he's got multiple myeloma, but he had renal creatinine to 2.8, some significant renal disease. His kidney started getting better. Now he's getting hydration, IV. He's doing, raw plant-based diet, some juicing, and we're doing special things with it. We have some other people with colon cancer, et cetera. Now, people that just go with just the nutrition alone, it's a little bit questionable. And so the point you make about doing a combination, an integrative approach, I think may be point on. And we see this not only with cancer, but some of our other illnesses, where an integrative approach with an aggressive plant-based diet with some extra things as an adjunct to the nutritional stuff seems to be helping, and it helps the body tolerate, and it probably suppresses these side effects. I don't know. That's just what we're seeing anecdotally. So I think we need to do more studies on this.
So nutrition plays a role. I mean, I lead a nutrition support team at the University of Chicago, and I have a significant number of patients who have cancer. And a lot of patients may have bowel obstructions from the cancer, or a lot of people they may have, just nausea and vomiting from being on all the chemo. So we have to figure out foods or, how to keep people hydrated just to even tolerate some of the chemotherapy. So nutrition, hands down, plays a critical role in treating cancer. And, for a lot of my patients who have, bowel obstructions and cancers, may have spread beyond traditional means to treat the cancer, the nutritional support is really the thing that's keeping people alive the longest. And I've seen people, stay around longer than some of the results that some of the chemotherapeutic studies are offering, basically. But again, it plays a role, and I know there's a lot of folks who are just want to do the nutrition by itself. That it hasn't been well studied. And I know you hear anecdotal things like, I've had this person get cured by this person, and I was healed by this food. Like these are the stuff that if it is happening, it needs to be better reflected in the healthcare literature. Because and if people are truly getting healed by certain foods and certain herbs, then it is their responsibility to figure out how to set up some of these clinical trials so we can actually look at what's going on objectively and figure out a way to replicate it so other people can reap the benefits from it. And also, so we can figure out, are there side effects? Like who's the person who's really going to reap some of these benefits? But right now, we just don't have that data, and that's why when you talk to a lot of physicians or health professionals, we may say some of those claims are questionable because people haven't really supplanted or supported it with the scientific data.
Gotcha. Real quick, we're running close on the hour. I'm going to warn our audience, we're going to go over a little bit. You touched on this, but I just want you to, stage 4, stage 5 cancer. Can you just kind of give us a quick rundown on the stages of cancer and how we treat them, maybe from 1 through 4 and 5, just to kind of give people the kind of a basic understanding?
Yeah. So, I mean, when you're talking about stage 4, I mean, all you're doing is just talking about the size of the tumor and more or less the spread. Okay, so at the higher stages, there's more spread. At stage 0, stage 1, the cancer really hasn't spread anywhere, and typically those cancers are treated with surgery. You just take the cancer out and go about your business. Sometimes, depending on the oncologist, they may or may not offer some chemotherapy or some radiation depending on the cancer. But for the most part, those cancers can be cured with surgical resection. With stage 4, this is where the cancer has spread to distant areas. We call that distant metastasis. So stage 4 is typically something that's going to require chemotherapy and radiation, and surgery typically is not offered for stage 4 cancer, primarily because it's spread beyond the actual colon and the example of colon cancer. So just removing it from the colon is not going to cure anything. You still have cancer potentially in other organs like the liver, the lungs, and maybe even the body wall.
Gotcha. And so the other thing, I think this is an important question here. I've heard some people dismiss their polyps. Should they be concerned about making dietary change? So you get your polyps, and I've heard of patients say, "Oh, I had a couple of polyps, they were removed, and they go back." What say you to someone who's had, they get their first polyp or the second polyp, they're on the standard American diet? What say you?
Yeah, so I definitely tell people to, decrease their meat intake and increase their fiber intake. And there's one good study that was actually done in people of African descent here in America, where they're comparing us, African Americans, to folks in rural South Africa. So in the United States, African Americans, we have amongst the highest rates of colon cancer in the world. But in rural South Africa, it's amongst the lowest in the world. So the question is, why is our brothers and sisters across the pond, why are their rates of colon cancer so much lower than ours? And there was a researcher, a guy named Stephen O'Keefe, that sought to look at that difference and sought to answer that question. And what he did was he predominantly focused on the diet. Okay, so he did an amazing study that came out in 2015, where they took rural South Africans and put them on the standard American diet for a couple of weeks, and then looked at markers of an increased risk of developing colon cancer, and also how the diet affects the bacteria. And they took African Americans and they put them on a standard rural South African diet for 2 weeks to also see how that diet affected our risk for developing colon cancer. And it was really amazing study. So in terms of looking at the risk of developing colon cancer, they specifically did biopsies of the colon, and they were able to look and see how frequently the cells were replicating. So they take these biopsies, and you can do special stains on the cells to see how much turnover in terms of cells in the colon based upon these stains, how much turnover is actually going on. And if the cells are turning over frequently and replicating frequently, that in of itself potentially can be a sign of an increased risk of developing colon cancer, because every time the cell replicates turnovers, that's an opportunity for a DNA error to happen. And that is essentially how some of these cancers can form, at least some of the polyps and everything can form. So, and they also looked at the diversity of the gut bacteria. So we know that having a diverse gut bacteria can potentially decrease our risk for developing colon cancer. So when they took the African Americans, at baseline on a standard American diet, our cells are replicating like crazy, and our bacteria was not as diverse. They put us on that real South African diet that's super rich in fiber. Really a plant-based diet, didn't really have any meat. And what they found was the cell replication slowed down, and also our bacteria in our gut became more diverse. And that was just 2 weeks.
Just 2 weeks?
Just 2 weeks.
Wow.
Just 2 weeks of getting on a plant-based diet.
What study is this? What study is
this? Was this? South Africans eat a lot of meat. What tribe?
No, rural.
Oh, yeah, okay. Yeah. So there's not like in Johannesburg where everybody's pretty much on the.
Even in the village, they literally have places where you go just to roast meat, and they don't have any vegetables there. It's very interesting.
So they focused on specifically a tribe that was pretty much all vegetarian, and a lot of their fiber was coming from resistant starch in the form of they're eating high maize porridge. So high maize is just like it's kind of like cornmeal. It's almost like it's pretty much like cornmeal, except it's a little bit different and it has more fiber and specifically resistant starch. So the study, what I liked about it, you could see exactly the food that they fed everyone on the rural South African diet and the standard American diet. But specifically in the study, the rural South African diet was a plant-based diet.
What was the name of the study? Who's the author? I'm gonna look this up.
I think it was colon cancer diet, microbiota, something along those lines by Stephen O'Keefe.
Stephen O'Keefe. Okay.
And it came out in 2015. Now, they took the rural South Africans and looked at their colon before they got on the standard American diet and before they got on, our diet, everything looked good. So the colon, the bacteria was diverse, the cells weren't replicating real fast. But then they put people on 2 weeks of our standard American diet, where they're literally giving people like French fries, hamburgers, and hot dogs, all the stuff that we typically eat in America, and a whole bunch of junk food and processed foods. And within 2 weeks, their cells started to replicate faster, and then their gut bacteria became a little bit less diverse. So the study really just shows how 2 weeks of a healthy diet or even an unhealthy diet can impact our bodies at the cellular level. So it's really just a phenomenal study that I definitely recommend all the folks who are interested in plant-based nutrition, especially as it applies to colon cancer. It's a good study to look up.
Wow. Yeah, I'm gonna find that. I'm gonna put it in our notes so people can look at it. We went over time, and it was well worth it. We could probably go another hour. I really thank you for your comments. You can't go to a natural show without a question on cannabis. So 1 or 2 words: cannabis and colon cancer. Any data?
So I'm a cannabis advocate, and in the state of Illinois, I'm actually the reason why cannabis is covered for irritable bowel syndrome. And a lot of my patients, a lot of my cancer patients are using cannabis. Whether or not it has an impact on colon cancer, like most things with cannabis, we need more studies. And unfortunately, over many years, just because of the legal issues with cannabis, it's hard to study cannabis. And even today, it's still hard to study cannabis just because it's not legalized at the national level. So you do have cannabinoid receptors in the colon. So there's a whole bunch of them. So there definitely is a potential for cannabis to have some anti-inflammatory properties within the colon itself, which may, lend itself to decreasing the risk of colon cancer. But that is, it's something that just needs further study.
Gotcha. Now, you using your patient for what, pain control or what?
Yeah, pain control. So a lot of my patients who are getting chemotherapy where they have nausea and whatnot from the chemotherapy. So I use it for pain and also as an anti-nausea medication. And in general, I definitely rather have people be on cannabis than some of the opiate pain medications because it's safer. So the craziest thing about physicians, there's a lot of physicians who are completely against cannabis, but they're prescribing, derivatives of heroin all the time. And it makes no sense to me. Derivatives of heroin that literally have been associated with increased mortality. So right now, white people, I think white people between the ages of 30 and 50, their mortality has it's more people in that population dying. And the reason is opiate pain medications.
Wow.
Opiates in general, but you have a lot of people still prescribing these medications, but still saying things like, "Oh, well, cannabis is gateway drug." It's just like you're prescribing the drug, like you're talking about. I don't want to give a gateway drug when you're giving the real thing. It makes no sense.
Don't stand around the gate, just going through.
Right.
Maybe that represents their drug preferences in college. As we wrap up, Isosa, any comments? I mean, you counsel patients around the country, around the world, essentially. I imagine you've come across patients with colon cancer, colon disease. Any issues you've dealt with or comments you want to make regarding your experience?
In 2 minutes?
Whatever time you want to use. I want to go over. Yeah.
There was a few. I mean, there was a few things that came to mind, but the colon cancer patients I've had have been problematic because of the care team surrounding them. So I had a guy who was smoking, older African American guy, colon cancer. I think it was stage 3 at the time. Mm-hmm. His oncologist, I basically gave him recommendations. He wasn't eating as much. He needed to eat a little bit more, but he was eating processed meat. He was eating the physician had put him, they often, especially lower demographic, less people with less money, they're putting them on Ensure. And it's always the milk-based Ensure. And they're like, drink this 4 times a day. So I basically was like, listen, this is what we're going to do. I'm going to put you on the plant-based Ensure. I want you to reduce, I didn't even say get rid of meat. I said get rid of all processed meat because he was eating so much sausage, bacon, these kinds of things. I also wanted to help to soothe his digestive tract and get a lot of nutrition in there. So I was going to have them make smoothies with Irish moss and other things, which is very soothing to the digestive tract. And literally the oncologist went through my recommendations and not only crossed all of them out and initialed them, he then told the patient to eat ice cream all day.
Mm.
And I was just like,
Yeah.
And this was a person of color?
Say that again?
This was a person of color? The patient was a person of
Yes.
color?
Yes. And it's just, I've seen this so many times where it was just for me maddening because kind of how you said, it's like very common knowledge. The World Health Organization says, processed meat is like a big risk factor for colon cancer. And then for him to continue be doing it. And then I also focused on behavioral things. Like I wanted to find interventions to reduce his smoking, which no one else mentioned. They were just going to allow him to continue smoking. And so these are the kinds of things that I've encountered that have been kind of disturbing because I don't understand how someone who's treating cancer tells someone to eat things that have been shown to feed cancer. I don't understand how that works. And then the other thing I would say is with the things that you were talking about with just research and diet, I think about things. This is why I'm so fascinated by nutrigenetics and nutrigenomics, because I really think we need to start way early. And instead of like, of course we have to treat people when they actually have these things, but I think that we should literally be able to look at someone and be like, you have these SNPs or you have these issues. Now let's create a plan before you even get any of these things to deal with it completely holistically so that, and monitor it. This is how you were talking about screening. It's like we could start way early. You have these SNPs, you're doing all this holistic stuff to prevent it, you're getting the screenings. And then that's more of a proactive way of promoting someone's health versus just waiting until they get to the place. You know what I mean? Where they're falling apart. Now they need chemo and all the stuff.
Yeah, and I 100% agree with you. And I mean, that's one of the reasons why we really need to figure out how to change the healthcare system in general, because our healthcare, we spend so much on like treating cancer that we don't even treat well. Like our treatments are just not even all that effective, especially for like the stage 4 cancers. And that's just the truth of the matter. But we don't spend much time in prevention at all, much time and money in prevention at all. And a lot of the reason for it is just prevention. Most people don't feel like it makes money. And most hospitals can't, benefit off prevention. But it's still like this is a change that just needs to happen because our population, we're getting sick younger and younger. So Chadwick Boseman is just a good example. And I don't know his, genetic risk factors or his family history and whatnot, but the brother seemed like he was in shape. And he also, to my understanding, adopted a plant-based diet. But we have to really engage in some of these changes early on. So like the nutrigenomics model that you mentioned, I mean, in an ideal world, like kids can get tested for this stuff.
Exactly.
In an ideal world, pediatricians, when we do the well child check, like nutrigenomics should be part of it. But the problem is doing those tests are expensive and insurance companies are just not paying for it.
Yeah. And in my, I think in the ideal world, it wouldn't be expensive. We'd be able to do it super early. And we'd also be able to, because people don't understand their own bodies. People don't know. They just like, oh, I think my grandmother had the itis. They don't really, you know what I mean? They don't really remember what the specific disease was. You know what I mean? Because people don't talk enough about these things.
Yeah.
It's like we need to talk more about it. People need to talk to their parents and their grandparents and find all the stuff. And then they also need to do testing and then start making proactive plans. Yeah. Not waiting. And I get frustrated because I get a lot of people who don't want to come and see me until they have, the stuff has gone crazy. But I love it when people come to me when it's before, well before things have gone crazy. And they're like, I'm just trying to figure out how to, make my diet better and make my lifestyle better.
Yeah.
So Celeste, I mean, this case with Chadwick Boseman being diagnosed so early, I mean, we know these cancers start decades. I mean, this, tragedy as it is, brings about the opportunity to start raising that discussion among your patients in the pediatric area. I mean, this discussion has gone to that point. I mean, what are your thoughts in this regard, and how might this affect your approach with your patients?
That's very true, and I was actually going to ask Ed to talk on. I think, like Asosa said, we don't know our bodies, and so talking to people, our children, about pooping, and it's a funny subject, and people get bashful and shy, but a lot of times when I ask patients how often do they poop, they may say once a week, they may say once every other day. The pooping scale is all over the place. And I actually had a patient who said 3 times a month. And I've heard adults, this was a child, but I've heard adults say things like this. And people are not realizing that is a major problem for the gut. And so I wanted Ed to kind of touch on that some, how important is it that we are pooping daily? And, how, of course, fiber, but other things too, to kind of keep the gut moving, because I think a lot of the processed foods and sugars and salts that we're eating are making sludge in the GI system. And, until they get majorly backed up, and sometimes we do have to go in and do enemas, they don't recognize that it's even a problem.
Yeah, so a lot of good points in there. In general, I tell people the normal range for human bowel movements based upon large population studies, and the people that actually have studied this, I mean, they look at the NHANES database of the nurses study, and they actually ask people how frequently you're having your bowel movements. So the majority of people are falling anywhere between 3 times per day to 3 times per week. So that's where most people should fall into. And if you're having more than 3 times per day, especially if it's diarrhea, I mean, you may want to talk to somebody about that. If it's definitely less than 3 times per week, that may warrant a conversation. So everyone's body is a little bit different. I know a lot of people will say, well, I should be going every day. There's a lot of people who do go every day, but there's a lot of people who go 3 times per week, and there's nothing wrong with them. But when you're talking about once a week or once, every couple of weeks or 3 times a month, like, that's a problem. So that's clearly abnormal. As far as what you mentioned in terms of how do you have conversations with kids about poop, that's a great point. And we need to really be able to start some of these conversations earlier, so kids are comfortable talking about poop, but also kids can turn into adults who are comfortable talking about poop, because there's a lot of adults who are just uncomfortable talking about this stuff. And that in of itself is probably a risk factor for some of these early diagnoses of colon cancer. So I wrote a children's book called Do You Know Where My Food Goes? And the book is really just all about digestion. And I wrote it to really help young kids get better equipped to have the conversation about their gut and their intestines and food, but also to help their parents understand some of this stuff. Because I see a lot of folks who come to my clinic. These are educated adults who don't know, where their colon is, and don't even know proper anatomy or proper terminology. And it's hard to have a conversation. I mean, you want to talk about, do you know your family history? If your family or yourself, you don't even know the language to even have that conversation about your family history, that's a problem. So, I've seen people come in, and these are people like educated lawyers, like, somebody had cancer of the boo-boo. And for me as a physician, when I hear cancer of the boo-boo, I'm like, I don't know what you're talking about. Like, I kind of know what you're getting at. Like, I don't want to be a stickler, but like cancer of the boo-boo is not, that's not a term that we use. And what frustrates me, I've seen a lot of my non-Black colleagues kind of use that same terminology. So they'll come and tell me, like, yeah, the doctor said that you got gut cancer. And I'm like, well, where's the gut? Is a lot of stuff. Like, where's cancer?
Yeah.
I feel like Black people make up very creative ways to talk about this.
Right.
That's I may need to change the title of this talk, Cancer the Boo Boo. Now, go ahead.
I do want to share one point that I didn't touch on. So it's good to know symptoms that should prompt early evaluation. Okay, so I know we talked about colon cancer screening based upon age and family history, but we didn't talk about symptoms that require a conversation with a health professional. So if you're having blood in your stool, especially in your 30s, at any point, if you're really having a lot of blood in your stool, instead of just assuming it's hemorrhoids, you should have a conversation with someone whether or not that in of itself should warrant a colonoscopy. So I've seen a lot of people come into my clinic with blood in their stool, and they may be in their 30s, and we do a colonoscopy, and they have either a large polyp that was on its way to turn into a cancer, or a cancer itself. And I've seen horror stories in which people, they were complaining of blood in the stool, and they were treated for hemorrhoids over and over and over again for years, and no one ever offered a colonoscopy. And then, out of frustration, they finally come see me, like, especially if it's African American, they're like, man, I just felt like I'm getting run around. They're just doing the same thing. This is still happening. I asked for a colonoscopy, but they said I don't need one. It's probably just hemorrhoids because I'm in my 30s. Then they come and see me, and I diagnose a colon cancer. And for Black women, I see it even worse. I've seen a lot of sisters get diagnosed with anemia. And everyone just assumes because it's a Black woman, anemia is because of heavy menstrual periods from fibroids. And I've seen people like, they never even complained of heavy menstrual periods. They're just using a regular number of pads and everything. And for whatever reason, I've seen people in their 30s where the doctor's just like, well, you know what? It's probably fibroids. That's what's causing your anemia. I know you're not seeing a lot of blood, but we should do a hysterectomy. And they'll literally have a hysterectomy.
Oh, wow.
Literally have a hysterectomy. And then the bleeding is still going on. And now, there's no uterus anymore. So you can't blame it on fibroids. So then they come in and see me. And I'm like, are you seeing blood in your stool? Yeah, I've been seeing blood in the stool. And you told your doctor who took your uterus out that you're having blood in your stool and not heavy menstrual periods? I told him that. And no one ever offered a colonoscopy. And we do a colonoscopy, and it is either Crohn's disease or a large cancer, or it's something that's in the gastrointestinal tract that was causing the problem to begin with. And now this poor 30-year-old woman got a hysterectomy. And I'm like, did you want more kids? Like this is
it's a thing. It's a thing I see with a lot of women with fibroids and Black women, and there's research on this, that Black women are routinely offered hysterectomies, myomectomies, invasive procedures well more than white counterparts. Yeah. It's a thing.
And that is honestly, it's clearly established in the research and the literature. And I agree with you. Like, I've seen this on more than one occasion, not like one isolated incident. It's just like, 35 years old, like, why did they take your uterus out? Oh, well, they said it was the cause of my anemia. And then I'm just kind of like silently rolling my eyes. And it's sad. So, like, women out there, like, don't let them just take your uterus out, especially.
And also the first line. Connect the two things that, like what Celeste said earlier about constipation, and also what you're talking about with gut health, because I see a lot of women with fibroids. Many women with fibroids have gut issues, and usually they have high levels of beta glucuronidase. Their body's just recycling estrogen. So I started doing this thing where I do GI effects tests on these women with fibroids, and almost every single time you find that their gut flora is a mess, and they have high levels of not so great enzymes, all kinds of problems, and they're constipated. Yeah. So constipation can also be a result, or sort of like a spin-off of having hormonal imbalance.
Yeah.
Wow, that's impressive. I'm going to let that be the final word, other than GMO wants us all to be cloned. I think, as the East Selling Carbonet show, I'm glad we had this time together. Thank you very much, Dr. McDonald. It's, this is a treasure. We went over 23 minutes intentionally because I wanted this important information to get out. Celeste Sosa, as always, thank you for your valuable input. And I'm going to carry us out. You guys wait behind stage, and we'll finish up after I close out. Again, thank you very much for joining us tonight. And this is a very, very important topic. I put early on in the comment to help us make this go viral. We want you to really like and share, subscribe and like this show, and share with all your friends. Each of you should try to share this with about 20, 30 people. This very valuable information, not only in the standard stuff that you hear, because you get a lot of things online, but Dr. McDonald is well-trained. It's the best institutions around. However, he's went off the beaten path and understands this whole process of cancer in general and colon cancer in particular in a very specific way, and gives you some alternatives to the traditional approach. He's a doctor who understands the traditional approach and understands the approaches outside of the traditional approach, and it will help you navigate these two areas as well. And the information we shared here, I think, does that a great deal. For those of you who want a program, online.montgomeryheart.com is our online boot camp. It shows you how to detox, clean your system out in the event that you have some health issue, whether it's colon cancer, polyps, or the like. It helps you. And of course, if you have any questions regarding what was discussed on this show or any of our other shows, you can email us at wellness@montgomeryheart.com. So again, thank you for attending. We went long. We did that intentionally. I'm sorry. Those of you had to cut out early, you can always come back and look at the video. But again, thanks for your attention, and thanks for your wonderful questions. They were very helpful. So until next Monday, we want you to help keep it fresh, natural, and live. And again, have a good night.